In Australia, the standard treatment for T-cell lymphoma is very similar to the European approach. We have a reimbursement scheme in Australia that is pretty restrictive, and most of the drugs that are available are those that have been demonstrated on randomised phase 3 studies. The treatment paradigm is generally chemotherapy, often going to high-dose therapy with autologous stem cell transplantation. In young patients, they may move to allogeneic transplantation if they've got poorer prognostic features. In the elderly group, it is standard chemotherapy. Because of the high relapse rate of T-cell lymphoma, either with standard or even after autograft, salvage treatment depends on availability of the chemotherapy regimens. Our most common regimen would be gemcitabine that's used in salvage. If they haven't had an autograft, they'd often move to that. And we have limited access to some of the biological agents. So the HDAC inhibitors such as vorinostat or romidepsin are limited, and there's some named patient programs for other drugs. We don't have pralatrexate, we don't have belinostat, and in terms of cutaneous T-cell lymphoma, bexarotene is difficult. So that actually is a significant problem for us in terms of treating patients. On the other hand, it makes us attractive from the point of view of getting clinical trials. So we've managed to have a number of clinical trials in T-cell lymphoma and been successful contributors to those.